Good morning, everyone. We are delighted that you all joined us today for this very exciting panel. The purpose of this panel discussion is to explore the evolving landscape of health information exchange and interoperability through the lens of dental software developers, informatics experts, and of course, providers. We will discuss opportunities for integration of electronic dental records with medical record software, the exchange between dental practices, and the future of data exchange. We will also hear panelists' reactions to the federal regulatory landscape related to health information exchange and interoperability. And I should also note that the views and opinions expressed in this program are those of the panelists and do not necessarily reflect the views or positions of the ADA. So it is my distinct privilege to introduce our panelists this morning. Each of them has a very accomplished professional background, which I know will help color our conversation today. The first is Dr. Ryan Hungate, the Chief Clinical Officer from Henry Schein One. We have Dr. Ray Jeter, an Assistant Professor at the Dental College of Georgia at Augusta University. Dr. Yaya Manzoor, the Chief Dental Officer at Rodeo Dental and Orthodontics. And Ms. Arna Meyer, a Technology and Change Management Consultant. And I'm Dr. Jennifer Thompson, Chair of the Digital Dentistry Technology and Innovation Subcommittee of the Council on Dental Practice, which is a very long name, and a general dentist practicing in New Mexico for the past 16 years. And I'll be the moderator for this session. So I'll just open by making a few remarks about the state of technology in dentistry and the ADA's position on interoperability and data exchange. So we know that the adoption of health information technology in dental offices has drastically increased, marked by the widespread use of practice management systems, electronic dental records, and related software and applications. And larger health systems, examples being academic locations, FQHCs, armed services, or federally supported care models, have already taken some steps towards medical dental integration and interoperability. But findings from a 2023 ADA survey revealed that private practices, including single site solo practitioners, group practices, and larger multi-site locations, have also achieved a 98% adoption rate of electronic practice management and health records on some level. And in that same survey, private practice providers indicated that the number one consideration for purchasing new software, cost aside, is the seamless integration of software, including imaging and referrals, business analytics, and data from primary care medicine, such as a patient's medication information. Yet a majority of these providers, myself included, identify that their practices have ongoing issues with sharing clinical, administrative, and imaging data with other providers and systems. So our goal within the ADA is to ensure that our professionals are equipped with the tools, the knowledge, and the support necessary to deliver the highest standard of care. And the ADA believes that for the optimal patient benefit and with the insurance of confidentiality safeguards, appropriate health information should be available at the time and place of care to practitioners authorized by the patient through the development of an electronic-based patient health record. And that the architecture of that record should be open and compatible with all segments of healthcare, with no barriers placed upon profession or specialty or the type of care delivery system. It must be accessible to all dentists, not only those affiliated with larger health systems, academic systems, or large multi-site practices, but also our smaller dental practices as well. And following that thread, we strongly support incentives and investment in dental-specific standards-based technology to ensure interoperability and compatibility. And I would also add that notably last year, we passed policies which explicitly call for the inclusion of PDMP compliance tools and the use of DICOM standards across applicable products or systems. policy statements that really have the weight of more than 159,000 members showing their support for interoperable technology. And so with those opening remarks, I would love to invite our panelists to make their own few opening remarks about their perspectives on the current state of dental interoperability, and would also love to hear why and how dental data exchange, interoperability, and standards are prioritized within your efforts or organizations. So Dr. Ray Jeter, let's start with you.
Hi, good morning, everybody online, and I'm honored to be asked to speak. My statement's going to be pretty brief. I absolutely agree with Rebecca that Jennifer, sorry, that we're in the middle of an evolution. I think it's obvious that it's happening at the enterprise level, federal, university, stuff like that. But I really do think that the creation of clearinghouses, both for payers and health data, I think that the explosion of DSOs is where it takes that initial bolus that was created by the enterprise level and is really broadly distributing it throughout our nation. The small independent practices, the ones that have light DSO in the background, if they have it, I do think that they're using interoperability already. You think about digital prescriptions for our lab cases. You think about just business management, how we interact with our payers on the web. All that is interoperability. Integration, we have tools for integration. The EHRs are maturing over time. I am excited that the vendors are here listening to this presentation because, there's two ways to skin this. You can integrate, bring it into the EHR all the way, or you can bolt it on, through APIs and stuff like that. And both means are happening right now robustly. So I think that we're not at the beginning anymore. We're pretty much deep into it. And I think what we're bucking up against right now is the perception of what interoperability is. And it's happening, even though, it's not obvious. And I think that the guidelines that were set out by law, HIPAA, PII, that sort of stuff, I think, the next step has been taken where industry in the middle layer is really, really, really making it integrated into our daily practice. That's all.
Thank you. And let's turn to Dr. Ryan Hungate.
Hey, good morning, everybody. It is an honor to be here, and I couldn't be more excited to talk about the future of not just healthcare, but really the critical importance of this medico and dental interoperability. Because, like, in our increasingly interconnected world, the separation between medical and dental care, I just really think is no longer sustainable. Patients expect and deserve seamless integrated care, and that considers their overall health, not just isolated aspects of it. And you're seeing that in those demands, like Ray, you were just talking about from both DSOs and even single location practices. This medico-dental interoperability is the key to achieving that vision. By leveraging electronic health records, patient management systems, and standardized data fields, we can ensure that data health information flows seamlessly between medical and dental professionals. This not only enhances patient outcomes, but also improves the efficiency and reduces errors. There's all kinds of data out there that shows this. I know at Henry Schein One, we are committed to leading this transformation, developing innovative solutions that really bridge the gap between medical and dental care. And together, with everybody talking about this now and bringing it to the forefront, we have the opportunity to create a more unified and effective healthcare system. And I think we can really lead the way on this because we see our patients more often, right? It's just how it works. We can be the tip of that spear and ultimately improve the health and lives of our patients. So I'm pumped to talk about this today.
Well, I'm glad that you're pumped. We're all pumped as well. Dr. Yaya Manzoor.
Yeah, good morning, everyone. Thank you all for putting this together. I think it's a really, really exciting and very important issue that we need to discuss and also lead. I think it's also a really good time. We're at an inflection point as a profession, but also healthcare in general, where it's important for us to be able to pause and open up the aperture and really look at this holistically and how do things integrate. And we can either lead and innovate, or we can stand idly by and continue this fragmented data information system that makes it A, more expensive, B, more burdensome, and ends up affecting the patients as well. So I'm glad we have some vendors here as well, so we can discuss some of the key challenges to achieving true interoperability in dental practices, but also in medical and dental integration as well. I think this is a unique opportunity for us to be able to come up with the standards and protocols so that we're all speaking the same language, while maintaining security, the integrity of the electronic health records, but also on a higher level, just certain things like, if you get a CBCT and it's a DICOM file, but you have a certain program that can't read that one and you got to convert it. There's all sorts of other clinical things that can be integrated and standardized along the way. I think this aspect of data and how we read it and how we speak to each other, the future is really cloud-based. The future is artificial intelligence-based. And it's also the future's now, honestly, and we really have to make some moves and come together and band together and come up with a coordinated effort on how we're going to move forward.
Thank you. I definitely hear you saying that we have a lot of moving parts, and that's why we're so happy that leaders like you are on the call with us, and also listening in and joining our webinar. And Miss Arna Meyer.
Hi, good morning. So unlike my esteemed peers, I am actually not a dentist, and I'm not even American. And I fell into dentistry a little bit of an accident, but I've been in and around the data exchange world within dentistry. I started in practice management software, and then I've moved into operations and technology within small, medium, large, and institutional dental settings. And what's driven me absolutely crazy is how inefficient it is to get information from point A to point B. And I've worked in other countries where it's a flatter exchange system, and information will exchange within seconds, and there's remittance of certain transactions within seconds. And so for me, this is part of my perspective is just, we can do so much better. And I'm starting to see the promise of that. It started back in the electronic health record initiatives and meaningful use, and getting that project started at a federal level with the Department of Health and Human Services. Dentistry thankfully got their toe in the door, and that's actually what's helped us get to this point today. And so where I get really excited is just starting to see the promise of expedited data exchange and standardized data exchange. So those efforts haven't been in vain. It's taking a long time, relatively speaking, but we're getting to the point where we're actually seeing that information being able to transact through different health records, both dental health records and now into the medical health records. And so I'm really passionate about this and quite fiercely passionate about it. There's so much money to be saved, and the burden has always been on the practitioner's end. And so anything that we can do to reduce costs and to reduce errors on the provider's end, dentistry, especially for single practice owners, is getting very expensive, and it's very time consuming, and there are ways that we can cut that down. So this discussion is really, really pertinent to that from a administrative point of view. But I also agree with everything that everyone has said to this point, and I'm really, really happy to be here.
Fantastic. Well, thank you all for your thoughts and opening passionate statements. And I know that we have sort of touched on some topics that we'll be discussing. So that was a good little teaser for all of you joining us today on what we'll be talking about. So we're going to move on to more of a moderated discussion, and I'll try to direct a question to one of you specifically, but then we'll open it up to anyone else who'd like to comment. We really want it to be an open conversation. So let's just kick off the discussion by directing a question to Dr. Hungate. What responsibility do developers of digital health tools, electronic dental records, and other software vendors have in ensuring electronic health information is accessible to those who need it at the time they need it?
Great question. I believe it's almost everything, right? Because it's interesting. I think one of the things that was left out when a lot of people said, "Hey, you know what? We need electronic health records," and they said, "Rah rah." Remember, there's that big move by the government. We're going to pay for everybody to do it. We'll even subsidize it. And then all of a sudden, they all did it, and they were like, "Ooh, we forgot one thing. We need it also to also be interoperable." And they were like, "That's too late." Right? So there's these things out there that I believe not only that the software companies could help with, but also there could be standards set by maybe the federal government or other governing bodies out there that I think will push a long way. But otherwise, not only are the software companies trying to make it their responsibility to be able to share information back and forth, and at Henry Schein One, we have contracts not just with your DSOs and your single location practices. We also have it with government contracts as well, right? So the entire armed forces, they utilize our Dentrix Enterprise platform. So they require us to be able to pass that information between their systems, and Cerner is a great example of this. We need to make it more broad. We need to make it more standardized. It's not as simple as that. Obviously, everybody here probably knows about fire standards, HL7. It's not as simple as that. There's also the protocols to have to transfer that information back and forth, transform it, and things like that. But we're taking this very seriously. We're even working on a set of standards that we think that particular hospitals would like from dentists, because it's interesting. It even goes as deep as, do they want some of this data from us? Do they want everything? Because there's responsibility when we pass this data. So we're trying to find those objective pieces of data that we can pass back and forth and they can safely ingest. And then vice versa, right? We want to be able to ingest it back into those records, because we have a lot of, and I love it that these DSOs are pushing the limits on all of this. And I'm happy that Dr. Mansour is on here he can talk about this too. They're pushing the limits on all this in a good way and asking for this, because as they expand into other places of healthcare or have another partnership with another larger healthcare institution, you're going to see the demand for this increase in a giant way. And the software companies have that responsibility to supply that data when needed. The Cures Act helped a lot of this as well, and I think that we're ready in somewhat, almost already, but probably by the end of this year, you're going to see most of at least the Henry Schein supported platforms be ready for this initiative.
Yeah, I have an additional comment. This is Ray Jeter. I think that the DSOs, as rapidly as they're starting up and as broadly as they're starting up across the nation, they really do have an enabling function. These are multi-site locations that are spread out over multiple states sometimes, and they need to communicate amongst themselves, let alone communicate with medical. So taking what was built at the federal level, which you referenced a couple of minutes ago, I think that's hugely, hugely important, that distribution of those now normalized standards. Normalized to the sense that, yes, we can reliably expect the data to be successfully sent back and forth. So I totally agree with what you're saying on that.
The other thing I'll add to that really quick, Ray, is that DSOs, we love our single location practices, and I was a single location practicing orthodontist as well. But we don't have hundreds of thousands of dollars to pay lawyers. We don't have hundreds of thousands of dollars to pay security, executives to come in and look at this stuff. So what's nice is that the DSOs can come in and say, hey, look, here are the pieces that you need to standardize to protect all of these single location, but not just us as the DSO. Here's what our lawyers were able to say. Here's what we want. Here's the standard that we want it in, and here's the speed at which we want it. But that will help. That trickle down effect really does occur, where we can gather all that data and make it more automated for some of the single location practices out there.
Absolutely. It's I always say clinical excellence is the ultimate currency, and data is what drives behind that, right? That's what we do, is we make data-driven decisions and evidence-based decisions. And the faster we can have data flow, if we're doing general anesthesia and we find out the kid or the patient has a heart murmur, for example, we need to get an echo. Think about how much time is wasted by not having that communication or not being able to have that bi-directional data exchange with the cardiologist. So everything is so integrated, but we're seeing everything still so fragmented. But I like the direction that we're moving, and really the collaboration between companies such as Henry Schein, other tech companies as well, and medicine, but also amongst the dentists, the solo practitioners, which I was, which both my parents were as well before they retired, and group practices and DSOs and everyone in between is really in the same boat, rowing in the same direction now, to be able to improve the speed and quality of information and data, and also quality outcomes, quality clinical outcomes as well.
For me, the responsibility for vendors, for anyone who is developing digital products in dentistry, is multifaceted. The first is they need to understand the standards that are actually mandated in federal regulations. So this goes back to, it started before HIPAA, but HIPAA actually mandates the standards that are required to be used for transactions between systems for different administrative functions. And so it is imperative that if you are developing a digital tool to be used in a clinical setting, that you adhere to these standards. Like at this point, it's a non-negotiable. And what those standards exist so that we can have, what, as Dr. Jeter said, this normalized data exchange. But in order to have that exchange, we need to have the fields in the practice management systems, in the clearinghouses, in the payers. Like, we're an interconnected system, and the data needs to move throughout all of this. I look at it as infrastructure, right? We need it to be able to move and not lose any integrity as it bounces through everything. And so by and far, the biggest responsibility that our vendors have is to adhere to the federal regulatory standards, and not because not for any other reason than they exist. It's mandated by HIPAA, and this is how we actually achieve the rest of our goals, is adherence. And so, and participation in those standards development would be brilliant. I'll at some point I'll talk about the work we're doing over at Weedy, but we just need more representation on the dental side at HL7, at X12, in Weedy, in these places where we're discussing and trying to develop. But dentistry is just so underrepresented, and that's where medicine is really getting ahead of us.
Yeah, this is Ray again. You have to be at the table at these organizations. You know, as we were preparing for this presentation this morning, HL7 sent out an announcement for their big meeting coming up, where they're going to have a connect-a-thon, which proves out what she was just talking about. These are hugely important events because we all know what the standards are and stuff like that, but how you interpret them, how you box them up, how you send them, how you unbox them, that all has to be proved out. So, yes.
We're looking for volunteers. We did cancel the last Connect-a-thon because we didn't have participation. So for dentistry specifically, like, we desperately need the dental industry to step up, and the vendors are the first step in that, in developing to standard and then coming to the table and testing so that we can get it into the clinics.
We definitely will be circling back and talking more about standards, because we know that it's vitally important. Dr. Jeter, at the center of everything is always our patients, right? What role do patients have in managing their dental health information in an interoperable healthcare ecosystem, and how can their rights be safeguarded?
Yeah, well, like Arna said, we're all kind of, at our level, we're all bound by HIPAA and PII rules. But the patients, you know, when you go to medical, you could have 3 or 4 hospitals or major clinics in your city, and you're going to have a portal for each one of them. Some of the portals connect to each other, like, I don't want to mention brands, but some of them you can, all put in one app and all that sort of stuff. But the ability to see your medications, the ability to see where there's errors in your patient record, okay, that is part of the um, partnership we have with our patients. It's one thing to treat the patients, to diagnose the patients and stuff like that, but it's another thing to manage their health information, and the patient is integral to that. So having the patient the ability to access this information, and there are now, talk of having dental portals, okay, so they can schedule, so they can, get Prevident refills, so they can, see what happens, so they can do their billing on, paying online, stuff like that. This is hugely important, and it brings us up to parity. Well, not all the way to parity with what's on the medical side. So yes, it's not a one-way trip. The patients have a role in this, and we appreciate that role. We want them to have a role in this. There's patient-supplied information. Think about genomic information that they can buy, home test genomic testing, okay? There's stuff in there that has dental import. They might come in there and tell you. Now, would you know what to do with it? No, but you might write it down in the record, and it might get uploaded to their medical record. In that case, the provider there will see, oh, the patient stated that they have this, that, and the other genomic predisposition. Well, they weren't tested here, but I still noted it. Okay. We all weigh the data that comes in, and we give it different weights. Okay. But this allows the patient to be an active participant in their care.
Yeah, I completely agree. I think eventually it's interesting. There's also products out there that are allowing patients to even download and kind of decipher their data for the first time, right? So I'm sure everybody out here that has an iPhone has looked at the Apple Health application, right? It has a small interpretation layer. It's not perfect because sometimes you get, the lab tests back and it's just that gobbledygook that's typical that comes through. But at the same time, you do have a concept now of carrying your patient data around with it. So, we're looking at ways to be able to get that to them in a secure manner. Apple's doing a great job of doing this. I really think on the technology side, the pieces that are pushing this are things like automated forms, online scheduling, online bill pay. I want to be able to understand my financial information with healthcare. So like, Ray, you mentioned with the portals as well, this is the future. The goal, I think, for a lot of us are trying not to have hundreds of portals. It should be like kind of one portal. I don't know if we'll get to that sooner or later because obviously it is a strategic advantage. But at the same time, it is an advantage for the patients. We just need to at least be able to, no matter what that portal is, be able to get it out in a standardized format. So I do like, Fire and HL7 for those reasons. Apple's done a good job. Google Health, even, I don't see it as much, not an Android user, but at the same time, I know that they have that concept as well. Can't deal with those green bubbles.
This is an evolution. And we have to accept that it's an evolution. You're not going to have non-interoperability one day and interoperability the next day. We are literally in the middle of an evolution. And it's going to take time to get to what we consider now the endpoint. And at that point, we'll have a different endpoint. Patient portals for dental. I remember in 2014, 2015, and we talked about patient portals for dental. Would we need it? And people said, why would we need that? Now, if you don't have a portal, be it web-based or app-based or whatever, you feel like you're lacking as a patient, okay? Patients want this sort of information. They want access to this sort of information. HIPAA says that we ought to be able to provide some means of them getting access to this information without having to drag themselves into the office every time to get that sort of information. So this is a great way to innovate within our community.
Absolutely. I think that's a very important point, Dr. Jeter. As dentists, we always want things perfect, right? We're taught to live and die by half a millimeter of success. And we can't go from having no interoperability to being perfectly seamlessly integrated. We have to realize that it's a process, and we're going to have to continue to partner with the developers and the community to be able to refine it and perfect it. And it's never going to be perfect, right? There's just going to be the next version and the next version, because part of with patients being the center of everything we do, patients, we live in an on-demand society, right? Everyone picks up their phone and they want their Uber there in 5 minutes and their Amazon Prime to be there the next day. They want their data, and they want that their answers right then and there. And that's the way things are moving and evolving. And like Arna said, she's seen in other countries, the speed is just so much quicker. So it's really disheartening to see that we had to cancel something because we didn't have enough participation. We can't then complain about the problem if we're not trying to be part of the solution. So I really encourage, and even I'm going to challenge myself to be a bigger part of this solution as well, because we really owe this to our patients to be able to deliver on this.
Yeah. I'm thinking, what role do the patients play? What the patients have that we don't have is that reality check that the data is accurate. So that's the biggest role that patients play in this, is checking the validity of any data that exists in the system. We have a bunch of information that exists in databases within dentistry right now. A lot of it has errors, and we don't have a very good filtering and cleaning mechanism. I'm starting to see artificial intelligence attack that. And where I'm really looking at this, there's some key things. So the first is in insurance. Like, insurance is a big theme. So making it right now, when you're communicating with payers through a clearinghouse, if any elements of that patient information are incorrect, like name is spelled incorrect, date of birth is transcribed, those transactions tend to fail and have to be reprocessed and then sent back through. So patients are positioned to really help validate that data. But then there's consequences if medication is entered incorrectly, and like any drug-to-drug interactions and allergy interactions. Having patient eyeballs on the information that exists within the practice management systems there is going to be monumentally helpful. And then as to how we safeguard our patient rights, that's actually the bigger part of this question, in my opinion. This data is inherently valuable, and it is being shared and it is being sold. It needs to be de-identified. I think we need a way for patients to understand how that information is being used, and then give them a mechanism to opt out if that information is being used in any way to train artificial intelligence models and engines, if it's being used in any kind of research process. There are huge amounts of public health promises that exist in dental health records, and I really encourage the use of that. But we have to think through all the way through about how we are taking that data and using it at an institutional level. And patients really do need to, one, be aware that it's happening, and then two, to be protected, and then three, if they choose, have a mechanism to opt out of that data exchange as well. And so how we do that, we keep talking. I don't have the answer to that yet, but those are the things that come to mind when I take on that question.
So I definitely hear that data is currency, and we definitely need to take steps to make sure that that data is protected appropriately. And Arna, just to, I know you were just speaking, but I'd love to also throw something back to you. And we have mentioned this before within the group, health information exchange and interoperability is often discussed in a context which, frankly, is only applicable or accessible to these larger institutions and organizations, right? So how do we ensure that all providers, including these small independent practices like my own, are able to participate fully in data exchange?
It's a great question. And institutions are going to be at the tip of the spear of these efforts. They have the resources, not only internally as far as money and people are concerned, but they also have the resources to go and explore how to get more resources from the federal government to take these efforts on. And so they also then bear the responsibility of making sure that as they implement these solutions, that we do get it to trickle down, because interoperability can't just be at an institutional level. We can't just have hospital systems running the country, which it kind of feels like we're moving in that direction on the healthcare side. And I hear the same rumblings on the dental side as well. So it comes down to making sure that we build these products that, and again, it comes back down to these digital tools and these vendors that we're partnering with, that they adhere to standards, because the information that we exchange will be the same regardless of institutional type. There will be qualifiers that won't be necessary at a single practice location that may be necessary, let's say in a jail, for example. But that doesn't mean we can't use the same tools and platforms. Where we really need to understand the plight of the smaller dental practices. This can't be expensive, and it can't be cost prohibitive to implement a solution that actually can accommodate interoperability. And there are vendor partners out there. I worked for one that was it was open source. So it's just a matter of holding our vendor partners to the expectation that they build to standard, and then letting the big guys pay for it, and then just moving along. So keeping yourself appraised of what's happening, and going at the pace that you can, both afford financially and with the change management aspect, but understanding this is the direction we're going, and making decisions based on the fact that this is the future.
Dr.
Yeah, I
Hundy,
think that,
unmuted.
yeah, no, one of the things that I'd love to, briefly hit on is that, I know that there's standards of data transmission, there's standard fields within there. But one of the things that we're trying to figure out right now is what do they actually want, right? And on top of that, what is objective enough that you can move it across? So when you look at fields like patient lifestyle information, family medical and dental history, psychosocial factors, those are things that you wouldn't want to move across because they are not objective, right? Those are very specific to dental. They're very specific to how a doctor interprets them. But patient identification information, medical history, dental history, radiographic and imaging data, possibly, if they request it. And really, the other piece we're trying to figure out is that, do they request it or do we move it for them? Because what we're seeing is that it's more people are asking for the ability to get it instantly if requested. Because if you move something over there, let's take, for example, I move over a cone beam CT, right? And as a practitioner, I missed something on the cone beam CT. Now I send it to you, and guess what you just did? You missed something on the cone beam CT. So now we're both liable and we both get sued. These are the interesting pieces of this puzzle that make it not quite as simple as just making the data in a standard and being able to pass it back and forth, but also the mechanism on which we do it and when we do it. So that's what we're trying to figure out now.
I have a comment to that. Let's use diabetes and periodontitis as examples. Okay. It would be hugely beneficial for an internal medicine doc to know if a patient has moderate to severe adult periodontitis. Okay. You can go into grades if you want to and all that sort of stuff. It'd be hugely beneficial for the periodontist to know if the patient was well managed with their diabetes by being able to draw that data, hemoglobin A1Cs, from the internal medicine doc. So being able to accurately, objectively have a data element that's transferable and understandable by the other partner goes right to what you're saying. That's a perfect example of having that instant information back would absolutely impact the outcome of a given appointment that a patient has, either at the internal medicine doc's office or at the periodontist's office. Okay. We need that. As far as the EHRs and stuff like that, the APIs are given functionality where we had to invest huge amounts of dollars before, to integrate that functionality into a software package. Are APIs the solution? I can't say that, but gosh, they sure have sped things up. Okay. Again, going back to the DSOs, the DSOs have a need. They have a need to standardize. They have a need to modernize. When they go pick up these small practices and they aren't up to modern standards, so to speak, they have to put an investment in there. And there's no point putting an investment in there if you're going to have a diverse, unorganized, unstandardized pathway ahead. So again, I see the clearinghouses, I see the DSOs, I see the intermediate layer, the vendors. You've taken the structure that law has put down. You've seen the benefit of it. The doctors have seen the benefit of it. The patients see the benefit of it. And now there's opportunity there also. Okay. So I see that as the critical layer in making this happen. And like I said, it's already spilling down to the small isolated practices.
The way we're looking at it right now, and this is early days, obviously, is that what we're thinking about is that we will take the data that we have, transform it, put it in a standard data layer, and just kind of sit it there, right? So it's live and always sitting there. It'll be in somewhat of a universal format that people can adapt to. We'll also, so let's say it's like that one-off EHR that we didn't think of. Theoretically, they could go in, tap into this, and grab it right away, almost via somewhat of an API, but more of in a standardized format. And we're looking at, there's some standard layers of moving things back and forth, actually back from the fax days, believe it or not, that still exists. There's still a number one way of moving things back.
Data
Yep,
buses.
exactly. Moving things back and forth, and almost every single EMR out there or EHR out here still ingest data that way. So we take advantage of that. Now, like you were saying, I believe that APIs are an answer somewhat, right? Because there are some big winners in the medical world, similar to dental, right? Dental is less fragmented, right? The Dentrixes of the world, the EagleSofts, the Open Dentals of the world, you kind of cover 90% of what you need to with just those three. Similarly, in the medical world, if I do integrations with Cerner and Epic, I'm kind of good to go, in a way. So we have that responsibility to get that done at least, and make sure that at least the data is moving fluidly through those ecosystems. Because those, look, they're only going to get bigger. That's just kind of how that works in the world. Or if somebody starts to get bigger, they'll probably buy them. So we can kind of still feel secure in that methodology. But that's what we're thinking today.
What you guys are describing is a health information exchange, and they're actually defined by the federal government. So the Office of National Coordinator actually does, they're already well underway in building out these health information exchanges. What we need is to get dentistry into the health information exchanges as well. And so, like, again, we're building our own products instead of working with medicine. And so what I'm hearing, like, these efforts are already well underway on the medicine side. And so that's just another piece to add to this as well.
I think it makes it more economical too for the end user to participate in these. They're big organizations. They assume a lot of the risk. They assume a lot of the cost, like you said earlier. Without them, this would be impossible to do from the bottom up. So, yeah, that makes sense.
So, Anna, when you say health information exchange, is it more of an ideal thing, or are we talking more of like hey, Obamacare said go buy your EMR right now and you have to support HL7, and then all of them had like an intern project where they all did it and then none of them use it and it's not standardized at all? Like, how does that really function?
These are actually early days, and these are the big hospital systems that are coming online. I think the first one came on early this year. So it was it went through final proof of concept late last year. But these are actual I can't remember the name of them exactly, like TEFCA or something. I'll look it up and we'll get it out. But it's through the Office of National Coordinator, where the information is being ported from hospitals up into the cloud, so that it can get pulled down. And so we're starting to build a node network in the United States of data exchange. And so it starts at the hospital level, but it will infiltrate down, and dentistry will be part of that.
Yeah.
And so it was under the Cures Act.
It
We're really
is.
testing
Yeah.
my
It
level of I
it it was it was somewhat of a leading question, right? Because,
mhm.
and the reason I say that is I think it's being pushed more by the states even than the federal government. Because
North
if you
Carolina was pushing.
participate, yeah, because I
Yes.
think if you participate in the Medicaid programs, that's where dental is going to get it first, in my opinion. If you
Mm-hmm.
participate in Medicare or Medicaid, which a lot of our people on the viewer list right now, I know definitely do. In order to do this, you're going to have to participate in that exchange. So I think that's where that tip of the spear
Yeah,
is going to hit dentistry first.
yeah. And Dr. Mansour, I want to make sure we give him a chance to, because
Yeah.
I know he definitely does. And yeah, I'm the same way. I actually will work almost exclusively with federal and Medicaid programs, and so that's my lens as well.
Yeah, it tends, what we tend to see, even whether you have public insurance or private, usually when CMS wants something to be done, whether federally top-down mandated or through the states, the private sector ends up following in some sort of or fashion. So as that happens first, it'll have a trickle-down effect into the rest of the industry as well.
Yeah.
Dr. Manzer, you might have actually already addressed part of this in what you were just speaking about, but as I'm sure you can attest to, there are many competing priorities for our dental teams, no matter the practice setting. You know, sometimes it feels like we're barely treading water and trying to make it to the end of the day. And so sometimes that health information technology and interoperability issues often don't make it to the top of the list that our providers and our teams are really considering. So how can the industry educate and promote this case for data exchange? And what will it take to get dentistry on this path toward widespread interoperability?
Yeah, that's a great question. Dentistry is a very rewarding profession, but also very challenging as well, right? Physically, it's physical work. You're dealing with a lot of personality, staff, patients. There's a lot to take in. So as we're in the day to day and in the whirlwind of a work day, dental interoperability doesn't really make it to the top. But I think I don't think, I know if we can demonstrate true value into that day to day, into making people's lives on the front line, right? The RDAs, the hygienists, the doctors, the office leaders, the office managers, whoever it may be throughout the organization, and even the patients, if you can show them true value on how this is going to cut down administrative burdens, how it's going to reduce cost, how it's going to facilitate better quality outcomes of care, that's really when we're going to help educate. And when people have a perceived value and they see, wow, this, I got Mrs. Jones' medical consult back, within minutes, rather than this ping pong game of telephone or emails back and forth. It's really going to free people up to have less stress, to have better outcomes, and to save a lot on costs as well, because administrative burden is real. There's been times where I've gotten a CBCT, like Dr. Hungate said, I can't open it. And it's taken me 30 minutes, and I got IT, and I'm calling the other doc, and all that hurts is efficiency in patient care. So I think if we can tie in interoperability into every part of education of other CEs, whether it's in practice management CE or digital workflow on digital restorative or digital implant, if we can work that into and have it be part of the curriculum and part of the syllabus, I think that's where we're going to see true adoption, and a lot of people really buy into it. Are just going to bubble up to the forefront.
Yeah, and
I can.
I
Go
think.
ahead.
Oh, sorry. I was going to say another thing that I think will crack this open. Look, I'll say it. Probably money, right? Meaning that one of the things that I think people see here is opportunity. For a long time, if you look at what the average annual maximum is on a dental insurance plan over the last 20 years, it's the same, right? It's something like $2,000 or $3,000. Like when they were invented for the bay workers out west, it was the same number, which is just really upsetting. So I think there's a lot of people looking at the dental insurance and then looking at the medical insurance and seeing uncapped, and they're like, how do we figure this out? Right? How do we talk about this? Now, what is interesting, and another thing we're trying to solve, is how do I teach a bunch of dentists, right, how to code medically? Because that is really hard, right? That is one thing I believe that dental does really well. Our CDT codes are awesome, right? It's I did this, here's the code for it, done. The thing that's complex about our ecosystem is claims. Like, how do I write a note about this? What's the format that they want? What's the attachment that they need? That's the veiled piece that's not so easy. But file and claim, like in categorizing, it's super easy. When you go in the medical side, you've got a descriptive code, you got all these different category codes that happen, and then it's very subjective within the note. So one of the things we're working on is trying to make an engine behind this, telling people how to do it. If I want to code for this specific thing within medical, here's how you do it. So that's one piece. The second piece is almost like a decision engine, right? Where maybe I should code medical on this versus dental on this because the patient's reimbursement, it's cheaper for them and the reimbursement's better for me, right? You can start to help, all of the practices understand this and make it so, hey, I'm coding for this sleep apnea appliance or this sleep treatment. I don't even have to think about it, right? That's where this artificial intelligence starts to come in, or just looking at millions of claims, right? I see millions of claims every day, so I can see the ones that are reimbursed with the right data that's submitted versus the ones that aren't reimbursed, and I can start to make suggestions to doctors and say, hey, look, include this, this, and this, and also maybe you should look at medical filing before you're doing these other things. And there's already large DSOs out there they have the concept of medical file first. I think Pacific is one of those, right? So, there's people out there already doing this. It's just really hard, but they're putting process to it, so they're able to pull it off. I think that software will be the next step in taking this journey and helping people understand that. And also, look, maybe as a practitioner, you end up making a better living, and the patient gets a better treatment and pays less money. That'd be really cool.
Yeah, you're absolutely right. In some of these groups, figuring that out. And again, then in lies the next responsibility, which is education. But just for tangible numbers, I don't know how many people here are aware of the Council for Affordable and Quality Healthcare, but every year, they release regularly enough a index report where they actually they calculate the amount of money that we could save as a healthcare industry if we were to fully adopt. And this is just for EDI. So this is just for claims transactions, right? And in 2023 for dentistry, the industry could save $1.9 billion. And of that, 1.5 billion is on the provider side. So that's what it's costing us as an industry to not adopt interoperable software. And so just understanding that the administrative burden of the cost savings, the payers have already figured this out because they've got $365 million of savings. We've got 1.5 billion on our side of the fence. So just understanding the economics of this and understanding that the amount of money we could save by actually developing and using products to expedite these transactions, it's not insignificant. It's huge.
I also think we should also look outside the profession as well. I mean, I think pharmacists have done a really great job. The pharmacy profession has done a really great job doing interoperability. Again, I'm not a tech guy, but standardizing certain charging cables, where now everything's going USB-C. There's usually something that's best in class that wins in the free market, and that becomes the standard. And we have to go outside of dentistry, even outside of healthcare, like thinking outside the box and seeing what is the methodology that they came up with, the standards and protocols, in order for us to all be speaking the same language, to adopt the same format, the same syntax, et cetera, et cetera. And again, I'm not a technical person, but I do believe in studying other professions, other industries, to be able to learn best practices and then apply them to our own.
Yeah.
Yeah.
I think
And
in
look,
banking,
go ahead, yeah.
if banks could figure this out in the 80s, like, because I mean,
Yeah.
banking has the same kind of complexity as our health system does. But like, if we look at insurance, like it has the same kind of like three-tiered network. And they managed to roll out credit cards like Visa and MasterCard came up and through the 80s. And so if they could figure this out, they are not known for being forward thinking and fast moving, yet they solved this a long time ago because of the amount of cost and the pain associated with it. So the banking industry is another really good one that I normally have people look at when we compare industries for that reason.
Dr. Jeter, did you have a comment before we go on
I
to the next?
did. You know, the federal government laid out the boundaries of this. And, you know, there's laws there, like Arno was saying, that we have to adhere to, you know, if we're going to be successful. But the innovation is taking place at the layer below that. And so, you know, whether it's healthcare innovation or whether it's outside health and in other industry, those best practices, they need to be brought in. We need, and it's not that we need, the innovation is actually taking place though at the DSOs. The innovation is taking place at the clearinghouses at that level. Okay. And that's where the money is that they can invest it in. That's where the biggest bang for our buck is right now, as far as increasing the numbers of users of interoperability functions, because you got to reach a critical mass. You got to reach critical mass of people that are using it so that standard gets normalized, like we said at the very beginning here. At that point, then things, just due to the sake of modernization, will start to trickle down to the lowest levels of our industry, so to speak. Okay. Modernization is going to occur. It's going to occur either through attrition or it's going to occur through technology and embracement of new functionality. And that new functionality is through innovation. I think that's going to happen in the middle layer, is happening in the middle layer. So,
Yeah, I will also mention that there's some actually really sexy things that medical has that dental does not, right? So for a couple examples, medical actually adopted EDI and ERA, right? Where, you know, on the dental side, we adopted EDI in 1,000 different standards, right, and formats. We adopted ERA, and by the way, it's missing 20% of the information 80% of the time. So we didn't do that. Whereas medical said, hey, if you're going to be a participant as a payer, this is what you're going to do. And they said, okay. So now as a patient and as a practitioner, I can say, here's what your portion is going to be. Pay your portion today. And now I don't have AR problems, or it's really rare when the AR problems happen, right? Whereas on dental, I'm working on eligibility right now. It is a nightmare, right? We figured it out and it's going to be really cool. But at the same time, it was a nightmare to fix, right? And this is something that we needed very badly. So I think that by hopping over to the medical side or starting to integrate it more, you're also going to have some matter of fact things start to happen within our industry where maybe the payers will snap into it. Hey, hell, maybe they'll start to merge. I don't know. So I'm looking forward to that whenever it occurs.
And that administrative efficiency, definitely we want to touch on. But I do want to give a specific example on something that I'd love to touch on. And I know we were talking about things that will influence this conversation, but the dental profession, really in partnership with our medical and pharmacy colleagues, has identified some strategies to assist in prescribing opioids and controlled substances safely when needed. And in many cases, often due to these regulations, prescribers not only, one, must utilize electronic means for prescribing, but two, also need efficient and quick access to states' PDMP sites. So not the 6.5 minutes it took me to sort of log in, pull a PDMP report, download it, then upload it into my document center yesterday, because I don't have a third-party application that seamlessly integrates into my software that I have purchased. So since these features often are not included as a standard feature in most dental software, what advice would you offer software vendors and developers to make that a consistent reality? And what should providers ask their vendors for to make this featured standard, as opposed to needing to purchase an add-on in order to comply with regulatory mandates or at minimum to be responsible prescribers? And Dr. Hungate, you're unmuted, so I'll ask you.
I was going to say, who wants to jump on that grenade first? So it's interesting because there obviously are some costs to having to do these integrations. The electricity is somewhat expensive on these compute cycles, but at the same time, you know, we are saving a gigantic amount of time, for the practitioners and what they're being able to do. So I think ePrescribe is a great example of this. I also think that, again, this is where the states came in. So New York, I think, was one of the first and said, hey, guess what? All of you within the next year or two have to go through ePrescribe. It's just a legality. I think they started with their Medicaid programs. They got all 12 people that take Medicaid. And then after they got that, they were able to move on to everybody else. I kid when I say Medicaid, but that's just one of those things where the more people were able to push to those zones by making things look more advantageous, the better it is. And the software providers will do that. And what's nice is if you get one state to do it, we typically have to build it for all of them. So that's kind of what you end up seeing there. You end up saying like, hey, this is how we're going to build it. And for things like ePrescribe, they are low cost. Like they're pretty darn extreme low cost on those things because they're not a nice to have. It's a I have to have it. So typically it's a commodity. And whenever you see a commodity within a PMS solution or an EHR, if I decided not to have that, then everybody would have to move to something else. Right. So you end up seeing it kind of grouped into the cost of the PMS solution. If it's a cloud solution, the monthly piece on there, and we'll subsidize it in that manner. But I really think it's where the states can push for this or whatever it might be that they're pushing for. That's when you see that move. And it really all it takes is one decent sized state to actually make that difference.
I think about this differently. I think the infrastructure that has been built isn't thought through correctly. The fact that we're using portals, like I get why portals exist and why we're going in, but again, behind the portal, there's a database, and we need to have information. Like we need to have some kind of information exchange. That we've got to stop thinking about portals as a solution to healthcare if we're going to really get to interoperability. And so this is on the states to actually prop up maybe an API. I don't know how, yes, it's an API right now, but to get that information to be able to move, to Dr. Thompson's point, the amount of time it takes to come out of your practice management software, to log in, to go find that information. This isn't optional information at this point. Like it's getting the drug history and especially the controlled substances, from point A to point B, it needs to happen. There's very few states that are not requiring this. And so we kind of need to partner with our state partners here as well to actually get access to that information that can circumvent portals so that it can just populate in the system of record, whatever practice management system you're using. And that's separate from being able to prescribe. So this is just accessing a data point in a database. This is not prescribing information. This is just so you can make an informed decision. It's a tricky problem because, again, we've got all of these sunk costs that we've propped up around infrastructure that is useful enough that it's not painful enough to solve around. But the truth of the matter is we need that information to just come directly into our health records, whether that's a practice management software, an EHR, whatever we are that we're using, so that we can just see it in real time.
Wonderful, thank you. So I know we talked a little bit about administrative efficiencies, and there's really a few things that keep dentists up at night. And currently really top of mind in about 3 out of every 4 dentists is the dental team workforce shortage. And many practices are in search of clinical and business team members. And I feel like I need to have an octopus at my office that has, 8 hands who can answer the phone, check out a patient, set up a room, check dental benefit coverage, all simultaneously. And the dental industry really is beholden to administrative transactions that were built generally for medicine, as we've discussed, and haven't really been updated since they were first implemented. And as a result, the burden for dental offices is high, especially related to eligibility and benefit verification and claims processing. And I know there are many third-party solutions as well as work progressing to improve these transactions. But what opportunities exist specifically for addressing these administrative efficiencies? I don't know if anyone wants to jump in on that. Dr. Hungate or Arna even? Mhm.
Yeah, go for it, Arna. Take it.
Okay. Yeah, X12 has been the standard for a while, and working somewhere that had really early adoption of X12 and ERAs, like 835s we were doing almost 10 years ago. The claims processing, I break it into different functions. And what we have to remember is we've operationalized health insurance rules and called it business operations. And so what we've done in dentistry and in healthcare is looked at the boundaries that the health plans have set, and we've sort of said, okay, these are the parameters they're giving us to work with. We're going to maximize the benefits. And so what that's done is we've first then got into, we go into eligibility and benefits. And so that's a binary. We're trying to answer 2 questions under one transaction. Does this patient currently have insurance? Yes or no? And then, oh, by the way, can you just tell me everything that exists within that plan? So that we can then give accurate estimates when we treatment plan. And then the second thing we do, we make pre-auth, but that's part of a claim. So then we send a claim out, and then we get remittance back. And so each of those layers has its own transaction type that is sent out to a payer and comes back into our practice management software. They're automating that. Like once upon a time, we used to have to manually key it into a claim form, put it in an envelope, send it out. The insurance company would open that envelope, key it into their database, adjudicate the claim, key it into another thing, put it back in an envelope, send it back to the dental insurance, to the dental practice. They would open the envelope, put it back into their practice management system. So collapsing that into digital files and digital formats and exchange has already saved a ton of work. But where the administrative burden, we caught it on our opening remarks, it really saves in the amount of time that it takes to process this information from point A to point B, and the errors that can get caught. And it's really exciting. We are at an inflection point right now with artificial intelligence entering the game, because we've got these engines now that are actually starting to understand and learn the rules of the payers. And so, I mean, some of the products that I'm working with, they do all the attachment management. They get all the narratives. I don't have any people processing a transaction. So once someone has entered a CDT code and creates a claim, everything is handled and then posted back in. And unless there's an error, it's just transacting in, which that used to be 6 full-time people at some point touching that claim. And so there's a huge lift that technology is bringing to this. And that, again, it all is because of the standards, but these standards are built for medicine. Like, there's no denying it. We've added dental qualifiers to make it work for us. But again, that comes back to, we need more participation at the standards maintenance organizations and the standard development organizations, and up at the federal level to actually advocate for our inclusion in these standard sets, so that we, like, HL7 can't handle tooth numbering, and we don't have like the ability to do like referrals. And so those are big gaps that we need to bridge and we need to close. We don't have the manpower there at the moment to actually have those conversations and actually help make those changes in any kind of timely manner. But they are happening slowly but surely. But they're not yet. Dr. Hungate, thanks for letting me go first.
No, so this is one of the things I'm most passionate about, because it's the most messed up. And I also think it it leads to a lot of patient frustration. And even worse, it leads to patients not saying yes to the treatment they need, right? Because we honestly sometimes say when people go, how much does this cost? We go, I don't know. And we're being dead serious, right? Or we can go, I think it's going to be around X amount of dollars. Could you imagine if you check out on Amazon, they're like, I think it's going to be $63. Like, probably wouldn't go so well for them. But yeah, we do it every day in our dental practices. So, we've been working really hard on eligibilities. Now, what's interesting, and you talked about X12, 835s, even 837s when they come back. And then also the EDI information, the portals, because now they've just completely abandoned EDI information. Now they're building their own individual portals, which doesn't help anything. So this is where we've now used a multi-tenant way to go out to all these different sources, even bots, talking to bots on the phone. If you're thinking about Dentical and pulling down information, it's just goofy, but pulling it in and standardizing it in a format. So, Jennifer, you brought up the staffing problem earlier. I believe that one of our problems with staffing is that I have to go steal from another office because I don't have the time to train somebody on this stuff. I need somebody that has 7 years experience or 5 years of experience. What I want to be able to do is be in Starbucks, have an amazing experience with a smiling face and be like, dude, you want a job? I can train you in 3 days, right? That's where we need to be able to go with this, and I think the first thing that gets us there is a standard, right? If I could train you on a standard kind of EDI format, I could say, this is what this data means. It's always going to be in this spot. If you don't see it here, it doesn't exist. Right? This is where the history and limitations are. This is if they have ortho. If it's not here, guess what? It's not going to happen. It's not like sometimes the asterisk means it doesn't happen. Sometimes none means it is, right? Like there's all kinds of these weird things that happen right now. So we've been working on getting that into a standard format. The next piece is like Anna was saying, getting it into the PMS, because if we do this right, you never look at it. Right? You just plan treatment. It automatically calculates a patient portion. It automatically formats from artificial intelligence looking at the image. It puts it in an objective format. Hey, there's 32% damage on this crown. It creates a note for you. And if you submit this annotated image with this specific note that has been certified by the AI, the claims adjudicator goes, well, I can't argue with this. This is objective. Right? And they agree on this standard too. So we're on the precipice of having something really special happen in the dental side, which probably should have been there all along. The AI is making it more so the adjudication process will be better. So that is exciting. Mm-hmm. That will be unique to our industry. And I think we'll actually be ahead of medical a little bit because honestly, I think our images are a little bit more simple. But at the same time, I know that by the end of this year, you will have about 85% of the entire ecosystem automated, meaning that you'll be able to get about 85% of all eligibility information, and you'll be able to reconcile about 85% of all claims completely automatic. So now we're going to start to focus on how do I quickly surface the exceptions and not the rules, so you can concentrate on those and easily go after that data. So we're close, right? And you're going to see a lot change this year, and I think by the end of 2025, you should not be, you're always going to have the Plumbers Union of Northeast Connecticut that just doesn't hop on board. But at the same time, we'll even try to figure out solutions for that.
But I'd like to double click on that. And as we really think about it from our perspective in interoperability, thinking about it from the patient journey perspective. So imagine you're a patient, you want to get on your phone, you want to make an appointment, you don't want to talk to anybody, you don't want to be on hold. You want to input your insurance information so that your chart is built when you show up. Your breakdown is already there. Your insurance is verified. Think about how much time that saves and how much better that patient experience is. And will case acceptance go up? Will they be better informed and make better decisions about their health as well? That's a part that we really need to think about, because as you have, say you have a specific practice management system and you bring on a phone system and something that's an online scheduler, and you have these different pieces that are speaking to it, in order for that to be seamlessly integrated into the patient journey is something else that patients do demand. I saw some comments in the Q&A, like patients don't want a portal and patients don't want this. Well, patients want a good experience. I'll bet you that you all want it when you're patients and you want to be on there. So interoperability isn't just about the records, right? And about imaging files, but it's also about patient practice management and patient facing platforms.
And I know we're running low on time, and this is such a an in-depth topic that we could spend hours talking about. But I know we have quite a few questions, and we had some that were sent to us ahead of time as well. So I'm just going to turn to Rebecca maybe to read out some of the questions that we've received.
Yeah, I think we have a couple of really good questions, and unfortunately, we're not going to have time to get to everything, but I do want to have 2 questions addressed if we can. So I'm going to ask all of the panelists to try to keep it very, very brief. The first one, I think we can direct to Dr. Jeter, and that is that in academic centers, we're seeing medical dental integration and interoperability between their health systems. They're working and being trained in a situation that when they leave their academic and go into practice, a lot of times they can't practice in the same way that they were trained to. How do we address that challenge of interoperability where they're trained in one way and can't actually practice in the same way?
So it is a frustration. Even where I work, our interoperability is relatively limited with the medical side. It's being addressed, but we're not there yet. I hear it from our graduates. You know, they leave the school and they have a level of capability, and then they get to small town Georgia, and it's just not there. But yet they're doing, you know, digital impressions. They're sending off digital prescriptions to labs. I think it's the perception of what interoperability is. I think that's part of the problem. You know, we perceive interoperability as having a data dump of medical information into our health module. I mean our medical health module of our EHR, when it's much, much broader than that. I think Ryan talked about it earlier. I mean, it's more than the images, it's more than the health data. It's the whole footprint throughout our whole practice that, you know, is interoperability. Um, of all these feedbacks that I've gotten from my ex-students, you know, when you start talking about like that, they said, oh yeah, you know, we got that capability last year, or we got this capability, you know, a few years ago, and we love it, you know, that sort of thing. They don't see that as interoperability. Now, do they have interoperability at the high level like what we're talking about? Most of the time not. Most of the time not. But yeah, it's frustrating. And it's frustrating on 2 levels. One is the institution that I work at, not to mention names, even though we already have, you know, we're working at it. We're not there yet. We'd like to be further along. And then, you know, at the end user point out in some small town in Georgia, they don't have it either at this point.
Yeah,
So it is.
I really think, yeah, and I really think automating this is the only chance we got because, you know, it's one thing to be able to teach the students coming through right now. That's great.
Right.
We can definitely do that. But they'll even go into those practices and be like, dude, I got this brand new thing. It's called medical coding. They'll be like,
Yeah.
go learn how to do a crown faster.
Yeah, at this
Right.
point, we're
And
teaching them how to be informed consumers. That's what we're teaching
yeah,
them right now, is how to be informed consumers at this point. We're not teaching them how to manifest this. We're teaching them how to be informed consumers for stuff like this.
yeah, that's right. And that's where I think that if we can automate it for them and say, hey, look, this is the code I want to do, we could tell them, hey, you should go medical first on this. Here's what that should look like in a general format. Insert your different numbers to customize it for yourself, and off you go. That's the goal there. I think that's how we can get a mass adoption and people start to use that.
And Rebecca, was there another question that you'd love to share?
Yeah, and I'm going to try to summarize some of the questions that we received by registration and the ones that we've been receiving today over the panel. When we think of data exchange, we've kind of heard from you all, some of the industry standards don't meet the needs of the dental industry, right? Where do the standards need to go, and how do we get there?
Not a big question at all.
No, easy.
I'm like, Rebecca, you're perfect to answer this.
But there's examples. There's
There are.
HL7's, evolution.
Mhm.
I mean,
Oh,
yeah.
absolutely. I mean, like I mentioned, like it can't even handle tooth numbering systems. That in itself is a huge problem. Um, yeah, part of this is, again,
Okay.
I can count on one hand the number of practice management systems that have dabbled in actually trying to undertake this and implement standards into their solutions. And because of that, like we need more feedback. And it's by trying and learning and iterating that we actually get the data we need to bring that up to the standards maintenance organizations to develop better. I mean, I've looked at I'm speaking from a very narrow and limited scope of what I've experienced, and I'm very narrow in what I do. I work with one practice management system in particular, and I know it really well. And so I know the limitations just based on our efforts in trying to implement and adopt standards through that. But that's just one part of a bigger puzzle. And so it's, um,
And the functional communities, though, have a role in this too.
yes.
Some functional
Yeah.
communities have been way more active than other functional communities. And without the participation of those SME groups, you're not going to get the data elements defined for that functionality. So when she says we need to come back to the table, we need to be in these discussions, it's not all just these high level discussions. It's that given functional community defining what are the critical data elements for their functionality and getting
That's right.
those submitted to some sort of standards organization and getting those adjudicated and then running it from there.
Right.
That's
We
right.
haven't
Like,
done that holistically across the board
no.
yet. We've done it in certain disciplines, but not all disciplines.
And it's happening right now. What's cool is it's actually happening between the ADA and the FDI. They're trying to get it done at the FDI portion. We'll see how that goes because it's, you look at it from a world view, it gets even harder than if you look just in the United States. But look, again, I believe that the DSOs will push this in a gigantic way because they're going to say, hey, I need this data to get my business operations done, right? Give me this narrow set and I can go achieve what I need to achieve. And we'll start there, right? And we'll say, look, I can get it to you easily. Which EMR are you using? Done. And we've got made the first step. Because I think a lot of times people like to look at giant problems like this and go, wow, what's the perfect solution? Let's sit there and build on it for like 18 years. And by that time, we're like, oh, we missed our moment. Instead, like, let's just get version 1.0 out or the alpha out or something like that where we can get it out there and start. And then afterwards, just keep adding to it. I don't really care about the format so much, whether it's FHIR, HL7. We'll get the data there. That's actually quite easy because of the APIs and everything else. It's what are the pieces, that Rodeo Dental wants to be able to function in the most optimum way possible and give a great patient experience. If you tell me that, I'll make the data elements available. We'll make it in a standard format that moves it to where you need to be. And we can probably do that in a really short amount of time.
I love your
Dr.
optimism.
Banzer? Yeah. Dr. Banzer, did you want to comment on that?
No, I really want to echo what Ryan was saying. Is we always in dentistry we have a sense of perfection. We want this perfect solution, and it's never going to be perfect. It's just going to be the next version. Let's just take one step. Every system has its pros and cons. Nothing's ever going to be perfect, but we're also going to, just like Dr. Jeter was saying, it's an evolution, right? It's going to evolve, and whatever's most readily adaptable to change is usually what survives and what evolves. And we just have to take the next step, and then the next step, and the next step. And I think it's a real mindset paradigm shift for us to be able to do that, to just fine tune and really make things better. And then new problems are new issues are gonna come up, and we'll be able to solve for them as well. So I'd really encourage everyone to think like that rather than, well, this doesn't do this and this does that, so this is better than this. Well, maybe, and each person practice is different. Maybe somebody that does just fillings, for example, in their practice needs something different, that practices sleep medicine and needs to partner with a sleep doctor, needs to have access to those medical records. So I don't think it's black and white. It's a very gray area, but we can work together and come up with some solutions that'll help us become more efficient and enhance the patient experience as well as the treatment outcomes.
So I know we're coming to closing time, and we've had a really wonderful discussion. And in reflecting on these wonderful comments from you, our panelists, I think it's really clear that advancing data exchange and interoperability for the dental industry will require participation and collaboration from all stakeholders. And as Rebecca closes our panel with our final housekeeping items, I just want to really personally thank our panelists for your time and your expertise in contributing to this robust conversation on dental interoperability. And we recognize that as we navigate this federal regulatory landscape, our greatest changes may be market-driven, right? And not necessarily mandated. So I would love that we all keep that in mind as well. But adopting standards-based data formats and communication protocols really will be vital to facilitate true interoperability and secure data exchange between our care teams and other systems. And it's really our sincere hope that all industry stakeholders can collaborate and really align our efforts as we develop this roadmap together. And Rebecca, did you have any final housekeeping items?
I sure do. I want to announce the next interoperability and data exchange, and I see a typo already on my slide, but September 4th, same time as this, 10 to 11:30 a.m., we're going to have a part 2 to our federal regulatory panel on dental interoperability. Speakers will be announced soon, but we hope to have more information coming, more details about where the intersection of data exchange and federal regulations come. Just also keep in mind, we are looking for more topics, more interest, more speakers for this series. We're going to continue to have these conversations about where the dental industry is headed. And so with that in mind, I want to thank you for joining. Please remember to submit your post-panel survey. We do look at it and we do use it to guide us on these things. Clearly, we have work to do on EDI. I have flagged it, and I can promise you that will be a session, that will be a topic that we'll have conversations. And always, we're available for questions, comments at dentalpractice@ada.org. And that brings us to the end of today. Thank you.